September 30th, 1999. A routine procedure inside a Japanese nuclear facility goes wrong. 3 workers are exposed. One of them receives a radiation dose no human had ever survived before. What followed lasted 83 days. If you enjoy this kind of investigation, please subscribe, like, and share the video. Let's begin. On the morning of September 30th, 1999, inside a small nuclear fuel processing facility in Tokaimura, Japan, a routine conversion procedure was being carried out by 3 employees of JCO Company, a company contracted to prepare uranium fuel for research reactors. The task assigned that day involved dissolving uranium oxide powder in nitric acid to create a uranyl nitrate solution, which would later be transferred into a precipitation tank designed to ensure that the uranium mass remained below critical limits. The procedure being followed, however, was not the officially approved method outlined in safety documentation. Instead of using a carefully calibrated buffer tank that controlled geometry and concentration to prevent accidental criticality, the workers were manually mixing the solution in stainless steel buckets and pouring it directly into a precipitation tank whose shape allowed for the accumulation of fissile material in unsafe configurations. This shortcut had reportedly been used before in order to accelerate production. By approximately 10:35 a.m., the amount of uranium solution introduced into the tank exceeded the safe threshold. The uranium being processed that day was enriched to a higher level than what the facility typically handled, and once the volume inside the tank surpassed the critical mass for that configuration, a self-sustaining nuclear chain reaction began. Witnesses inside the building later described observing an intense blue flash at the moment of criticality. The light was not an explosion, nor was it accompanied by the structural destruction often associated with nuclear incidents. Instead, it was the visible manifestation of ionizing radiation interacting with the surrounding air, a phenomenon known as Cherenkov radiation, which can occur when charged particles move through a medium at speeds greater than the phase velocity of light within that medium. The reaction did not end instantly. Although it fluctuated in intensity, the criticality event continued intermittently for nearly 20 hours before being fully stabilized. During the initial seconds of the reaction, the 3 workers closest to the tank were exposed to extremely high levels of neutron and gamma radiation. One of them, positioned directly beside the precipitation vessel while pouring the solution, received the highest exposure. The radiation was invisible, odorless, and silent. There was no blast wave and no immediate external trauma. Within minutes, however, symptoms consistent with acute radiation exposure began to appear, including nausea and discomfort. Emergency protocols were activated, and the surrounding area was evacuated. Local authorities established a perimeter, and residents within a defined radius were instructed to remain indoors as precautionary measures were implemented to reduce further exposure risk. The plant itself was eventually shut down, and technical teams worked to halt the ongoing chain reaction by draining coolant and adding boric acid to absorb excess neutrons. The 3 exposed workers were transported to medical facilities for evaluation. At the time of departure from the site, there were no visible injuries suggesting the scale of what had occurred inside the building. The event, however, had already become the most serious civilian nuclear accident in Japan prior to Fukushima, initiated not by equipment failure, but by procedural deviation and insufficient adherence to criticality safety standards. Upon arrival at the National Institute of Radiological Sciences in Chiba, detailed dosimetric analysis was conducted to estimate the radiation absorbed by each of the three workers. These calculations were based on physical reconstruction of the criticality event, neutron activation measurements, blood analysis, and chromosomal studies performed on circulating lymphocytes. The results indicated that the worker positioned closest to the precipitation tank had absorbed an estimated dose of approximately 17 Sieverts. The Sievert is a unit used to quantify the biological effect of ionizing radiation on human tissue. Unlike the Gray, which measures the physical energy deposited per kilogram of matter, the Sievert incorporates weighting factors that reflect the differing biological impact of various types of radiation, including neutrons and gamma rays. At lower exposures, the distinction between these units may appear technical. At higher exposures, the difference becomes clinically decisive, because the Sievert reflects how severely radiation disrupts living systems. In humans, whole-body exposure above 1 Sievert typically produces symptoms of acute radiation syndrome. Doses in the range of 4 to 5 Sieverts are associated with a high probability of death without aggressive medical intervention. Exposures approaching 8 Sieverts are considered almost uniformly fatal due to irreversible damage to bone marrow and gastrointestinal tissues. An absorbed dose estimated at 17 Sieverts exceeds levels documented in nearly all previously recorded industrial or civilian radiation accidents. Laboratory analysis of the patient's blood provided immediate evidence of catastrophic cellular injury. Lymphocyte counts declined rapidly within hours of exposure, reflecting the extreme radiosensitivity of rapidly dividing white blood cells. Cytogenetic examination revealed widespread chromosomal fragmentation. Under microscopic observation, chromosomes did not appear intact or structurally continuous. Instead, they were broken into irregular segments, a pattern consistent with massive double-strand DNA breaks induced by high-dose ionizing radiation. DNA within human cells functions as the template for replication and repair. When radiation deposits energy along the DNA backbone, it can sever molecular bonds directly or generate reactive oxygen species that damage nucleotide structures. At sufficiently high doses, the frequency of double-strand breaks overwhelms the cell's repair mechanisms. When repair fails, cells either undergo programmed death or lose the capacity to divide. In this case, the destruction was not confined to a localized tissue region, but affected the entire body. Bone marrow, responsible for generating red blood cells, white blood cells, and platelets, is among the most radiosensitive tissues in the human body. The chromosomal findings indicated that hematopoietic stem cells within the marrow had sustained near-total functional loss. Without intact stem cells, the body cannot replenish circulating blood components. The implications extended beyond the hematopoietic system. Tissues characterized by rapid cellular turnover, including the epithelial lining of the gastrointestinal tract and the basal layers of the skin, depend on continuous cell division to maintain structural integrity. When DNA damage prevents replication, these tissues progressively lose the ability to renew themselves. The biological significance of 17 Sieverts, therefore, was not limited to an abstract numerical value. It represented a level of systemic molecular disruption in which the fundamental mechanisms of cellular regeneration had been compromised at their source. Unlike mechanical trauma, which affects discrete structures, high-dose radiation exposure alters the capacity of the organism to repair itself. The injury unfolds over time as existing cells reach the end of their natural life cycle, and cannot be replaced. At the time these laboratory findings were documented, the patient remained conscious and communicative. Externally, visible damage was limited. Internally, however, the diagnostic data indicated that the underlying biological architecture required for recovery had been profoundly impaired. Acute radiation syndrome, often abbreviated as ARS, is the clinical condition that develops after significant exposure to penetrating ionizing radiation delivered to the whole body over a short period of time. Its progression is not defined by a single symptom, but by a sequence of physiological failures that emerge as damaged cells lose the ability to replicate and maintain organ systems. The initial phase typically begins within hours of exposure and is characterized by nausea, vomiting, fatigue, and a general sense of systemic distress. These early symptoms are not diagnostic on their own, but their rapid onset following high-dose exposure often correlates with the severity of irradiation. In this case, the early presentation was consistent with an exposure well beyond survivable thresholds. After the prodromal phase, patients may experience a brief period during which symptoms appear to stabilize. This interval does not indicate recovery. Instead, it reflects the time required for damaged cellular populations to decline to levels incompatible with normal organ function. Because radiation does not destroy all cells instantly, the body continues to operate temporarily on residual functional reserves. As bone marrow stem cells failed, circulating white blood cell counts dropped sharply, leaving the immune system unable to defend against opportunistic infections. Platelet production declined, increasing the risk of spontaneous bleeding. Red blood cell production diminished, impairing oxygen delivery to tissues. The collapse of hematopoiesis is a central component of severe ARS and, at sufficiently high doses, becomes irreversible without successful transplantation of viable stem cells. Simultaneously, the gastrointestinal tract began to lose structural integrity. The inner lining of the intestines depends on continuous regeneration from rapidly dividing crypt cells. When those progenitor cells are destroyed, the epithelial barrier thins and eventually breaks down. This leads to fluid loss, impaired nutrient absorption, and the translocation of bacteria from the gut into the bloodstream. Systemic infection becomes increasingly likely as immune defenses deteriorate. The skin, another tissue reliant on basal cell replication, gradually lost its capacity for renewal. The outer protective layers depend on a steady supply of new cells migrating upward from deeper strata. Without that regenerative process, the barrier function of the skin weakens. Fluid balance becomes difficult to maintain, and the risk of infection increases further. Radiation at this magnitude also affects the vascular endothelium, the cellular lining of blood vessels. Damage to endothelial cells can increase permeability and disrupt normal clotting mechanisms. Combined with low platelet counts, this contributes to internal bleeding and instability of the circulatory system. Throughout this process, the central nervous system remains comparatively resistant to radiation in the dose range below approximately 20 to 30 Sieverts. As a result, consciousness may be preserved even as peripheral systems progressively fail. This distinction between neurological clarity and systemic deterioration is a defining feature of certain high-dose radiation cases. Medical management during severe ARS focuses on infection control, transfusion support, fluid replacement, and attempts to restore hematopoietic function. However, When the underlying stem cell population has been extensively destroyed, supportive care can only compensate temporarily. Organ systems dependent on continuous cellular renewal gradually lose structural and functional coherence. In cases exceeding established lethal thresholds, mortality typically results from a combination of overwhelming infection, multi-organ failure, and circulatory collapse. The progression is driven not by a single catastrophic event, but by the cumulative failure of tissues unable to regenerate after widespread molecular damage. Medical intervention began immediately after the extent of hematopoietic destruction was confirmed through laboratory analysis. The primary objective was to restore bone marrow function, as the collapse of blood cell production represented the most immediate threat to survival. A peripheral blood stem cell transplant was arranged using a compatible donor, with the intention of reconstituting the patient's immune and hematologic systems. The transplantation procedure involved harvesting stem cells from the donor's bloodstream after mobilization with growth factors, followed by infusion into the patient in the expectation that the cells would migrate to the marrow and begin repopulating the hematopoietic environment. In lower-dose radiation cases, such intervention can facilitate recovery. In this instance, however, the recipient's internal environment had been exposed to levels of radiation that affected not only stem cells, but also the supporting stromal structures within the marrow cavity. Successful engraftment depends on both viable donor cells and a functional microenvironment capable of sustaining them. To mitigate infection risk during profound immunosuppression, the patient was placed in a sterile isolation unit. Broad-spectrum antibiotics, antifungal agents, and antiviral medications were administered prophylactically and therapeutically. Repeated transfusions of red blood cells and platelets were required to compensate for the absence of endogenous production. Hemodynamic stability was maintained through intravenous fluid management and careful monitoring of electrolyte balance. Dermatological management posed a separate challenge. Extensive tissue injury required repeated assessment and attempts at grafting. Skin graft procedures were undertaken in an effort to restore barrier function and reduce fluid loss. In standard burn care, graft adherence depends on adequate vascular supply and regenerative capacity in the underlying tissue. In this case, tissue viability was compromised by radiation-induced damage to microvasculature and basal cell layers, reducing the probability of sustained graft integration. Mechanical ventilation became necessary as respiratory function deteriorated. Pulmonary complications in high-dose radiation exposure may arise from infection, inflammatory responses, or secondary effects of systemic instability. Intensive care support included continuous cardiac monitoring, vasopressor administration when indicated, and advanced life support protocols during episodes of circulatory arrest. During the course of hospitalization, the patient experienced multiple cardiac events requiring resuscitation. Advanced cardiac life support measures were initiated in accordance with hospital policy and family wishes. Each intervention restored cardiac rhythm temporarily, allowing continued physiological support. Decisions to proceed with resuscitation were made within the framework of existing medical guidelines and the expressed intent to pursue maximal treatment. Throughout this period, laboratory parameters were tracked continuously, including white blood cell counts, platelet levels, renal function indicators, and markers of systemic inflammation. The transplant showed limited evidence of partial engraftment at certain intervals, but sustained hematologic recovery was not achieved. Organ systems remained dependent on external support. The therapeutic approach represented one of the most aggressive radiation injury management efforts undertaken at that time. It combined established critical care practices with experimental regenerative strategies, reflecting both the unprecedented nature of the exposure and the determination to attempt full medical intervention despite the severity of the underlying cellular damage. As the hospitalization extended beyond the initial acute phase, the medical situation evolved from emergency stabilization to prolonged life support in the context of irreversible systemic injury. At this stage, the central question was no longer how to reverse radiation damage, but whether continued intervention remained medically appropriate. In Japan at the time, end-of-life decision-making operated within a legal and cultural framework that placed significant weight on family involvement and physician discretion. Advanced directives were not widely formalized, and withdrawal of life-sustaining treatment was approached with caution. In cases lacking explicit prior patient instruction, families often played a decisive role in determining whether aggressive care would continue. The patient remained conscious for portions of his hospitalization and was able to communicate during certain intervals. Reports from medical staff later indicated that he expressed distress regarding the continuation of invasive treatment. However, as physiological decline progressed, sedation and mechanical ventilation limited direct communication. Decision-making authority increasingly shifted toward family members and attending physicians. From a clinical ethics perspective, several principles were in tension. Beneficence required physicians to act in the patient's best interest, seeking recovery where possible. Non-maleficence required avoidance of unnecessary suffering. Autonomy required respect for the patient's expressed wishes. In high-dose radiation cases, where biological recovery is statistically implausible, these principles can conflict. Japanese medical practice at the time did not include widely established protocols for terminating life-sustaining treatment in catastrophic radiation exposure. Physicians were operating within an environment shaped by professional duty, technological capability, and societal expectations regarding perseverance in care. Once advanced life support systems had been initiated, discontinuation required explicit ethical and institutional justification. The case attracted increasing public attention as information about the exposure level became known. Media coverage raised questions about whether continued resuscitation and organ support constituted therapeutic persistence or medical overreach. Some commentators argued that the interventions provided valuable clinical data in an unprecedented radiation injury scenario. Others questioned whether the extension of life under such conditions aligned with humane medical practice. Hospital ethics committees and supervisory bodies reviewed aspects of the case during the hospitalization. There was no formal legal determination that treatment should cease. Instead, care proceeded within the established structure of consent provided by family representatives and the treating institution. The broader debate that emerged in the years following the incident centered on the limits of experimental intervention in cases where biological survival thresholds have likely been exceeded. Radiation medicine had documented few comparable exposures in modern clinical settings, and there was no established precedent for managing whole-body doses at this magnitude with prolonged intensive support. The ethical dimension of the case did not arise from a single decision point, but from the cumulative continuation of advanced interventions over an extended period, despite progressively worsening systemic failure. It remains cited in medical literature and bioethics discussions as a complex example of how technological capacity can extend physiological function beyond the boundaries previously encountered in radiation injury treatment. On December 21st, 1999, 83 days after the Criticality event at Tokaimura, multi-organ failure reached a terminal stage. Despite continuous intensive care, circulatory instability became refractory to pharmacological support. Renal function had deteriorated beyond recovery, pulmonary complications persisted under mechanical ventilation, and systemic infection contributed to progressive metabolic imbalance. Cardiac arrest occurred, and this time resuscitative efforts did not restore sustained function. The official cause of death was recorded as multiple organ failure, resulting from acute radiation syndrome. By the time of death, hematopoietic recovery had not been successfully established, and the cumulative physiological burden exceeded the capacity of supportive treatment to maintain homeostasis. The Tokaimura accident was subsequently classified as a Level 4 event on the International Nuclear Event Scale. Investigations conducted by Japanese regulatory authorities determined that the incident resulted primarily from procedural violations and inadequate safety oversight within the facility. The use of improvised methods to handle enriched uranium, combined with insufficient training and weak regulatory enforcement, created conditions in which criticality became possible outside controlled reactor environments. Legal proceedings followed. Company executives and supervisory personnel were charged with professional negligence. The plant's operating license was revoked, and Japan implemented stricter regulatory standards for fuel processing facilities. The accident prompted nationwide review of criticality, safety protocols, operator training requirements, and emergency response planning in nuclear installations. Within radiation medicine, the case became a reference point for understanding the upper limits of survivable whole-body exposure. Clinical data collected during the 83 days of treatment contributed to research on hematopoietic transplantation under extreme conditions, systemic radiation injury, and long-term organ support in catastrophic cellular damage. Medical publications analyzed laboratory findings, transplant outcomes, and intensive care strategies, separating empirical observation from ethical interpretation. Public discussion, however, extended beyond procedural reform and clinical analysis. The prolonged survival, following a dose widely regarded as unsurvivable, raised enduring questions about the relationship between technological capacity and humane care. Advances in life support systems allowed organ function to be sustained far longer than earlier radiation cases had demonstrated. The outcome forced institutions to confront the distinction between biological persistence and meaningful recovery. The Tokaimura accident remains one of the most significant non-reactor nuclear incidents in Japan prior to the Fukushima disaster more than a decade later. It exposed structural weaknesses in industrial oversight and revealed the consequences of deviating from established criticality safeguards. It also documented in clinical detail how high-dose radiation disrupts the regenerative foundations of human biology. 83 days separated exposure from death. During that time, modern medicine sustained a body whose cellular architecture had been fundamentally compromised within seconds. The case endures in regulatory policy, medical literature, and bioethical debate as a record of how procedural error, physical law, and clinical intervention intersected within a single event in 1999.